Good morning, everyone. This is the pulmonary section. I'm Charles Facelis. I will be starting the first section this morning with the pulmonary and finishing with the pulmonary, and then in the afternoon we'll be doing the endocrinology part. So I'm going to be going along with the notes here and talking about case number 1 initially. So let's turn to that. And this is a 24-year-old woman who comes to the emergency department with severe shortness of breath for 2 to 3 days. Her family states that she has a history of asthma and chronic nasal stuffiness. She has been maintained on bronchodilators and a steroid inhaler. She recently developed an upper respiratory tract infection and began to mildly wheeze. She has been taking an over-the-counter cold medicine over the last day. This afternoon she developed acute worsening of the breathing and called 911. She's a febrile, her blood pressure is 180 over 100, her pulse is 120, and respiratory rate is 36 per minute. The patient appears agitated. She's restless and is unable to speak in full sentences. She's using accessory muscles for breathing, and the physical examination shows discharge from a nasal polyp when you look around the nose. She has paradoxical pulse with inspiration. There's no jugular venous distension is noted. Pulmonary examination shows minimal breath sounds and a faint expiratory wheezes that are heard throughout the prolonged expiratory phase. Her heart is tachycardic, an S1 with a prominent split S2. There's no S3 or murmurs, and the examination of the abdomen is normal, and the examination of the extremities shows no thigh swelling or edema. So to recap, this is a young 24-year-old with a prior history of asthma comes in with shortness of breath, and on the physical exam, this looks like an asthma exacerbation. This should be the first thing on your list, the first differential on your list. So this should be the severe asthma attack that they have here. This is the first differential. Now, they have some other things here that could happen and bring a person that's usually young into the emergency department with shortness of breath, and spontaneous pneumothorax is one of these. Usually, there's really no history of asthma in this patient. You shouldn't find wheezing on the exam, and the pulmonary sounds at some part where the pneumothorax occurs, they should be decreased. The rest of the exam on the other lung should be normal. These are usually young people. Spontaneous pneumothorax occurs in young people, usually athletes, sometimes just without any prior history. An X-ray is definitely going to be helpful for that. Now, recurrent pulmonary emboli, and they don't have one pulmonary emboli because she's been having shortness of breath for 2 to 3 days, is another option. These people usually have some kind of hypercoagulable state. They've been in the hospital maybe the last week, maybe have gone through some surgical procedure. They've been staying in bed for a long time. Maybe they complain of thigh swelling or ankle edema, unilateral, because we know that about 90% of the clots that occur in the lung occur from clots that have started in the thigh or the lower extremity, somewhere in the lower extremity. So this patient doesn't have a history of that. So you think about it, but if you don't find the wheezing and you don't find evidence of asthma. And acute congestive heart failure, we should have jugular venous distension. We should have had some history of heart disease. We should have had usually systolic dysfunction that occurs in young people. Usually means that the heart is dilated and it's enlarged. We should have had some evidence on the cardiac exam that there is some problems with the heart. And we don't in this patient. And the bacterial pneumonia is another concept in this patient. Maybe this patient has bacterial pneumonia, but usually this would mean high fevers and cough productive and so forth. Now, the problem with bacterial pneumonia is that a lot of the asthma exacerbations, the most common reason people get to have asthma exacerbations is some kind of infection in the lung. Most of the time it's not bacterial pneumonia, it's usually viral pneumonia, though that's the most common one. They did a study recently within the last year, and they noted that 80-90% of the exacerbations in chronic obstructive lung disease and asthma are usually due to viral infections. So that's a thing to look for some kind of pneumonia. If it's bacterial, you need to put the patient on antibiotics. But this is not likely the only cause of what the patient is complaining about. So your initial diagnostic plan is to focus on these differentials and really rule out the stuff that like the spontaneous pneumothorax that you would treat differently. So the chest X-ray and the arterial blood cast would be one of the first things, and they do it in this patient. And, of course, the chest x-ray would show a normal heart size and no infiltrates. So the stuff about the pneumonia, the stuff about the pneumothorax, the congestive heart failure is almost ruled out now. You've got to focus on asthma. Now, people that have an asthma exacerbation usually breathe fast. They breathe quickly. Remember, the respiratory rate in this patient was 36. Most asthmatics are young people, right, and they're otherwise healthy. Most of them. So they breathe quickly, they blow off CO2. So they develop a respiratory alkalosis. So let's look at this. So this patient has 7.36. That's not a respiratory alkalosis. This patient has a mild acidemia. The CO2 is a little bit on the high side. Normal CO2 is what? 40. This patient's 44. And she's hypoxemic. So this tells you one more thing. If this is an asthma exacerbation, then it's likely a very severe exacerbation. Most patients with asthma, we said, if they're healthy, they blow off the CO2, causing a respiratory alkalosis. That pH should be over 7.4. The CO2 should be way less than 40. This is a normal ABG in a patient with asthma. This is the O2, this is the CO2, and this is the pH. So you could see that's what the patient should have. This patient doesn't have that. This patient has respiratory acidosis. That's a bad prognostic indicator. If you go back to the history of the patient here, and we are assuming that this is an asthma exacerbation so far, given the history and the negative other stuff that we've gotten so far in this patient, she also has other bad prognostic indicators. If you go back in her history, she has a paradoxical pulse. She has faint breath sounds, right? Silent lung is a bad prognostic indicator. She's using her accessory muscle. These are bad prognostic indicators, but this is the most important one of all. This means that she can't blow off the CO2 like all the other asthmatics. It means that she has respiratory muscle fatigue. This means that you may need to intubate the patient, or at least you need to keep things. You need to keep this patient really close by to watch this patient closely for intubation. So everybody clear about that? So we should have had a respiratory alkalosis like this. If we don't, then this patient needs to get intubated. I don't mean when the patient has this, but I mean when the patient has something like our patient where you develop an acidemia. So this means intubation. This patient, you could watch. They're going to do very well. Sometimes they may ask you a question, what's the most important parameter in an ABG, in an asthmatic patient, in terms of are they doing well or not? It's not the oxygen. So I could take this oxygen on this patient and look at this. I could go like here, 50. Doesn't change anything, right? This patient here is going to do well. They're doing well. Everybody agree with that? Yes. This patient here, even though their oxygen is higher than this patient needs to be watched closely. Maybe you will need to intubate this patient. And it has to do with the CO2 and the pH. So the most important parameter in this patient is the CO2. Make sure that that patient does not have CO2 retention. Some people say even if it's normal, this is a bad prognostic indicator. They should be blowing off CO2. Okay? So everybody clear about that? Good. So we talked about bad prognostic indicators. We talked about clinical indicators. We talked about labs. the ABG is the most important one. There's some other things that in the history of an asthmatic patient that will tell you this is going to be, these people have bad asthma. One is the history. So if the patient gives you a history of prior intubation, recent and frequent hospitalizations for asthma, that's a bad prognostic sign. Patients that have bad asthma usually have bad exacerbations. That patient you need to keep a close watch to. Patients that have nasal polyps have a syndrome where they have nasal polyposis, they have asthma, and what's the third thing that they have? Sensitivity to aspirin. So, if they're not told about this, they go over the counter when they have an upper respiratory tract infection like this patient did, right? And what did she take? She took some over-the-counter medication. Maybe this over-the-counter medication had aspirin in it. So now they got worse all of a sudden. These people usually have severe asthma attacks when they're giving aspirin. So said in a different way, what's the thing that you don't like to give asthma patients? Aspirin. A good percent of these patients that have asthma, nasal polyposis, and sensitivity to aspirin also cross-react with non-steroidal anti-inflammatory medications, right? Like Motrin, right? Ibuprofen, naproxen. So please be careful. This is about 30% of the cases cross-react. So keep that in your mind. If they don't give you aspirin sensitivity, they don't want you to give the patient non-steroidal anti-inflammatory medications. So what are the medications you avoid giving patients that are asthmatic? Aspirin and non-steroidals, because it may have triggered the effect of the asthma attack in these patients. Okay? So these people have severe asthma. They got severe asthma. So going back to our patient here, we talked a little bit about the clinical parameters in this patient, and we made a diagnosis on this patient. We did a peak flow too, and of course it's definitely decreased. It's only 100 liters per minute. These people should get, a young person should get about 500, 600. This patient definitely has asthma. So the question in this patient now becomes this. What is the most important thing? She's come in with an asthma exacerbation. What is the most important thing to do in this patient initially? And the most important thing is to bronchodilate the patient. That's the most important thing. Remember, what's the definition of asthma? It's an inflammatory process, it's reversible, right, and it's hyperactivity of the bronchi. So inflammatory hyperactivity that is reversible. But this patient coming in with an asthma exacerbation, you need to bronchodilate the patient. If you can't bronchodilate the patient, they need to get intubated. So the most important thing in this patient initially, the first step to do, this is the first step, is to put the patient on bronchodilators. Bronchodilators mean beta agonists. These are quick relief medications. They usually work very quick. So albuterol would be the first thing you give to this patient. You're going to give them oxygen too. That's fine. But this is the most important thing that you're going to do. This is what's going to help the patient the most. In the acute exacerbation, we're talking about just this patient. Now, in the emergency room, when people are short of breath, sometimes they're so short of breath, sometimes they can't do the meter dose inhaler, right? So you have to do handheld nebulizers, where they're sitting down in a chair and breathing the nebulizer. Either one works as well. So if the patient could do the meter dosed inhaled steroids, that's the ones that they have in their pockets, and they could do it well, it's just as good as the handheld nebulizer. Either one works. So you got to give the patient some form of bronchodilation, and some oxygen. That's your first step, the most important thing. The second thing in this patient is, we just talked about it, we said that these people have an inflammatory process. So in the long run, you need to think of how you're going to get this patient out of the asthma exacerbation. Since it's an inflammatory process, later down the line, you need to decrease the inflammatory process. So what's the second thing you do, you give to this patient, is you give them steroids. This is the concept that has changed for asthma over the last 15 years, is that we know now there's an intense inflammatory component to asthma. Whether you're talking about chronic asthma or an acute exacerbation, there's definitely an inflammatory process. So you will need to put this patient on some form of steroids. Now, if they ask you what's the most important thing, it's bronchodilators. Giving the patient steroids, whether you give the patient IV steroids or oral steroids, they have about the same bioavailability. They take at least 24 to 48 hours to act on the patient. At least 24 hours. So they will act at about 24 to 48 hours. So what are you going to do before that? You got to put the patient on bronchodilators. This is why this is the most important thing initially. Steroids could be given, we said, either IV, especially if the patient is short of breath, or oral as prednisone. When they're given IV, they're given as methylprednisolone. They have the same effect. So if they ask you, what's going to shorten this attack over time, the answer is steroids. What's the most important thing you do initially in the asthma patient is this. In an asthma attack is bronchodilate the patient. Okay? So everybody clear about that. So steroids is important because they shorten the attack, they get the patient out of the attack, but initially they don't have an effect. When we start the steroids in the patient, the concept is we use it for about 14 days, taper it off at about 14 days. So let's say you start the patient on 60 milligrams of prednisone. After a couple of days, they do well in the hospital. Well, what's going to happen? Then 3 days down the line, you lower it to 40 milligrams. After that, you lower it to 20 milligrams. You lower it to 10 milligrams and 5 milligrams. So 14 days, they will have this spurt of steroids. After that, you don't have to give them any more oral steroids. So oral steroids should be used only in the asthma exacerbation, the significant asthma exacerbation, and should be tapered off at about 14 days. Now don't get mixed up, because there are patients that will need systemic steroids. There are about 5% of the asthma population, 5%, that need systemic steroids every day. They wake up, they take 5 milligrams of prednisone or 10 milligrams of prednisone. We're not talking about those. 95% of them don't need systemic steroids. Those people that do need systemic steroids are called steroid-dependent asthma patients, and we'll talk about those. So that's in the acute exacerbation. There's a third thing you need to do in this patient, and that is to look for precipitating causes. What caused this patient to have an asthma exacerbation? What causes? What are the precipitating causes? Well, we just talked about some of them. What did I say was the most common one? Viral infections, right? So you did a chest x-ray. You want to make sure that there is no pneumonia, because that may get treated as a bacterial pneumonia, especially if the patient has fever and cough. So pneumonia is one thing. Especially if it's bacterial, this is treatable. And the other one is what this patient had, where they used some kind of over-the-counter medication that precipitated possibly the asthma attack. So remove aspirin and non-steroidal products in this patient, because they sometimes precipitate an asthma exacerbation, especially in the people that have the triad of nasal polyposis, asthma, and aspirin sensitivity. So that's your first three things that you do in this patient. You look for precipitating causes, treat the patient aggressively with bronchodilators, and give the patient steroids at the same time. The steroids are going to kick in about a day or two later, but you're okay with that. So let's see what they did. They gave the patient, on the further treatment plan, they gave the patient a nebulizer treatment with albuterol. They gave the patient oxygen, okay, and they gave the patient intravenous methylprednisolone. Like I said, you don't have to give the patient IV methylprednisolone. Oral is just as good, but if the patient is short of breath and cannot take oral, then you're going to have to give it IV. So they also gave the patient epinephrine because if the patient has a severe asthma exacerbation, severe, very severe, they give them epinephrine and theophylline. I want you to put a little star next to that this is only to be used in very severe exacerbations. 80-90% of asthma exacerbations that come in, the only thing you have to do is these three things. They usually go home. It's only severe asthma exacerbations. This patient, we used this. Why? How did we ascertain that she had a severe exacerbation? Clinically, she had no breath sounds. She used respiratory muscles. She had a paradoxical pulse. And her ABG, most importantly, showed respiratory acidosis. So in that patient, yes, you will give theophylline and epinephrine to get the patient out of the attack, because otherwise you're going to have to intubate the patient. If there is no improvement and a decrease in air movement with hypercapnia, so this continues, they say, yes, you will have to intubate this patient. So intubation occurs especially with an ABG showing respiratory acidemia. Okay? Very good. So a couple of days down the line, this patient will be hospitalized, of course, and let's say you intubated 1 or 2 days, you could get them off the ventilatory support once the bronchodilator takes into effect, or most of the time where we don't have to intubate the patient, a couple of days later, she will be doing very well, right? So she will be sent home, she will be discharged 1 or 2 days later or 3 days later, take your pick, on bronchodilators, plus oral prednisone, and we said this will be tapered off at about 14 days, right? So this is only for 14 days or so. Now, this patient, from the history, she was taking inhaled steroids before. Now remember, most of the patients, what do they take? They take bronchodilators and inhaled steroids. So you don't have to give them systemic steroids. So that should be continued. If the patient had some kind of pneumonia, you may have to keep the patient on antibiotics. So this is a possible regimen of a patient that had an asthma exacerbation and is being discharged home. After 14 days, you will have finished the oral prednisone and likely the antibiotics. So what's the patient going to be remaining on is a combination of bronchodilators, albuterol, meter-dose inhaler, plus the inhaled steroids. So you're looking at a regimen that treats about 80% of the patients that we see in clinical practice. This is it. A combination of inhaled steroids and bronchodilators. That's what we use in most adults. Most adults have a moderate to severe asthma when compared to children. Because adults are the children that didn't outgrow their asthma. 80% of children, by the time they're in early adulthood, they don't have asthma anymore. So that's mild. The adults that have the asthma, they had it as children and they still have it as adults, usually is the one that is severe. It gets better, but it's usually the one that is moderate to severe. So overall, if you compare adult asthma to childhood asthma, it is more severe. This is one of the reasons we rather treat them with inhaled steroids versus cromolyn, which is another chronic treatment for asthma, but doesn't work that well in adults. So the inhaled steroids are given to stop the inflammatory process and to reduce the asthma exacerbations. Overall, as a chronic treatment, when the patient is discharged, if they ask you, what is the most important thing for this patient? Now, we're not talking about the asthma exacerbation, right? We've sent this patient home. They're doing well. So over chronic treatment, what is the most important thing for this patient? The answer here, compared to when the patient came in acutely, the most important factor here is to take daily steroids, inhaled steroids. So everybody clear about that, because we define asthma as a recurrent inflammatory reversible process. So if you're going to stop the recurrence of it, you've got to stop the inflammation. The answer to that is inhaled steroids. In little kids, instead of giving inhaled steroids, you give them cromolyn, right? So in a child, here, the treatment would be bronchodilators plus cromolyn. We prefer cromolyn in children because even though it has milder anti-inflammatory effects, it works less. We said asthma in children is better. So it works better in them. We don't want to give them inhaled steroids. There is systemic absorption even if you use inhaled steroids. So in little kids, it stuns their growth. We don't like that. In adults, it's okay because they have more severe asthma. So this they have to take every day. This is a daily regimen. The asthmatic patient that has moderate to severe asthma has to wake every day and take inhaled steroids. So this is the cornerstone of chronic treatment of asthma, inhaled steroids. When do they take the bronchodilators? When they have symptoms, when they feel stuffiness, when they feel wheezing. So really the bronchodilators is on an as-needed basis, PRN. Some people have to take it frequently. Other people have to take it less frequently. Some people have to take this every day. Other people don't. So, but the cornerstone is inhaled steroids. Now, you've got to tell that patient that that's the thing that they have to do every day. They don't like to take the inhaled steroids for a couple of reasons. One is because it tastes bad. Number two, it causes oral candidiasis. And number three, it makes their voice hoarse. They lose their voice a little bit. This is called dysphonia. So in the patient that takes the inhaled steroids, you tell them after they take the meter dose inhaled steroids, you tell them to wash their mouth out with water so it doesn't leave a bad taste, it doesn't cause candidiasis, and it's less likely to cause the dysphonia. It's the dysphonia, for people that do speaking, it's very important. They lose their voice. It's very hoarse. So those are the problems. There is systemic absorption, again, let me repeat this, with the inhaled steroids. It's not as much as the systemic steroids, not nearly as much, but there is problems with inhaled steroids. So think of all the problems that a steroid would cause: osteoporosis, cataracts, and so forth, stunned growth in little kids. So you don't like to use it unless you have to. So there's studies coming out now that will tell us how bad these inhaled steroids are, but we know already. We know that there is systemic absorption. So if you don't have to use it, you don't use it. But this is usually the protocol that we follow in most patients with asthmatics. Now, the exception to this protocol is this. A small percent of the population, about less than 5%, will have very severe asthma. Very severe. And despite using all this stuff in the inhaled steroids, they still have symptoms and they still have exacerbations. So these are the people that are called steroid dependent. I should say very severe here. So these are called steroid dependent asthmatics. So in these people, we will have to use oral steroids. That's the bottom line. It's less than 5%, but don't be surprised if you find these patients in your practice, and sometimes they're presented on the boards. Now, what is the biggest change that has happened to this group of patients? Well, we hate using oral steroids. So could we use some other type of anti-inflammatory medication? Yes, there's a newer type of drug. They're called the leukotriene inhibitors. Leukotriene inhibitors, montelukast, and so forth. These leukotriene inhibitors get to the basis of the problem. They say these leukotriene byproducts are probably the ones that are causing the inflammation. So if we could use these inhibitors, we could stop the inflammation and maybe take them off the oral steroids. That's the importance of using these leukotriene inhibitors. They should be used only in this category for your purpose, not anywhere else. They're not recommended as a first-line drug anywhere else. So for your purpose, for the boards, they should be only used in severe asthma that are steroid dependent. Your goal here is what? To take them off the steroids, the systemic steroids. Okay? So only use here, but know them. They're very important. That's the only category you use them. Now there's one complication that has occurred with the leukotriene inhibitors, which is not really a complication. Some of the patients, there's some reports that when you use the leukotriene inhibitors, some patients have had this vasculitis occur in the lung. It's called Churg-Strauss disease. Churg-Strauss disease is a disease like polyarteritis nodosa, small and medium vessel vasculitis, but it involves the lung. So they put the patients on leukotriene inhibitors and they develop Churg-Strauss disease. So the question now comes, was the leukotriene inhibitors the ones that induced the Churg-Strauss? Likely not. Likely not. There's an association that they may ask you about, but it wasn't likely the cause. What these people likely had is they had asthma. It's common for the patients with Churg-Strauss disease to have the vasculitis, plus they're asthmatics. Plus they have eosinophilia. That's part of the whole Churg-Strauss disease. So they had them on oral steroids, and they suppress the Churg-Strauss disease. So now you take them off the oral steroids and put them on leukotriene inhibitors, and now they develop the Churg-Strauss disease. So it wasn't that the leukotriene inhibitors probably caused the Churg-Strauss. It was probably that these people had this disease, this small and medium vessel vasculitis already, and once they were pulled off the oral steroids, this came into the surface again. So you may hear something about that. There's an association. There's not a direct cause and effect. Okay? The other exception to this whole concept is, let's say we have a patient that has very mild asthma. They get exacerbations once every 6 months. They never go to the ER. Mild. Yeah, for a couple of weeks and then it goes away. They've never gotten intubated. So very mild asthma, you say to yourself, mild asthma, why do I have to use inhaled steroids? They get an exacerbation once every 6 months. I could just use bronchodilators as needed. So very mild asthma, you just use the bronchodilators. So these are the exceptions to about 80% that we treat of the adults. again, I repeat, of the adults, that we treat with bronchodilators and inhaled steroids. These are the two exceptions. So that's the treatment of asthma, and in the acute and the chronic state. That's what you should know for the boards. Now, in case number 2, let me go down to case number 2, and it brings up a couple of other things we should know about asthma. Over to case number 2. Look at this patient. This patient, in case number 2, has a form of asthma. She complains of intermittent cough. A 28-year-old woman comes to the clinic for the evaluation of intermittent cough. She recently started running several times a week and has noticed that the cough is much worse after she returns. She has noted occasional wheezing as well, particularly on very cold days. She's a non-smoker and otherwise healthy. She's a well-developed, well-nourished woman in no acute distress. Her temperature is 36.7. Her blood pressure is 108/70. Her pulse is 64 and her respiratory rate is 18. The physical examination is unremarkable. So you definitely think about a type of asthma that does this, where they exercise and they get these coughing spells. So there's these couple of asthma variants. One of them is called exercise-induced asthma. Another one is called cough variant, where they get these coughing spells, especially at night. And they wake up coughing, and then it goes away, and then they go back to sleep, and then it occurs again. So these are variants of asthma, variants of mild asthma. The other thing that you should definitely think about is reflux, esophagitis. So people that usually have severe reflux, right? This reflux is sometimes all the way up in their mouth and it goes into the lung, so they start to cough. They get a type of pneumonitis, inflammation of the lung from the reflux. But where does reflux more commonly occur? It doesn't occur with exercise, right? When does it occur? It occurs at night when people lie down. They wake up in the middle of the night with the coughing spell. And of course, you think about postnasal drip, because sometimes postnasal drip, when it drips out into the lung, people have coughing spell. It should not occur. It should not occur with exercise. It, again, occurs usually in the morning time or at night, because that's most of the time when you get the postnasal drip. Now, the question is, in this patient, knowing the definition of asthma, how do we make the diagnosis? Now, our first patient here, she had the diagnosis already made. We didn't have to worry about it. She was diagnosed. She has been hospitalized many times. We know she's got asthma. But this patient is the common patient that comes in your practice and tells you, you know something, I have this wheezing, I have a little bit of cough, and you consider asthma in her. So what do? How do you document that she's got asthma? Well, the definition of asthma is a reversible disease. So you have to find some way to document that she has a reversible disease. And remember, asthma, the definition is that the airways collapse, they get hyperactive, especially when the patient breathes out. So the pulmonary function test in this patient, that's the test to do. Pulmonary function test should show an obstructive disease that is reversible. That's what they should show. Now, the pulmonary function tests, remember, what are the obstructive parameters that we find on the pulmonary function test that show obstructive diseases? This is the FEV1 over FVC, or the forced expiratory flow between 25 and 75%. Both of these parameters measure flow, airflow. So the problem with obstructive diseases is airflow. These would be decreased in obstructive diseases. They would be decreased in emphysema and chronic bronchitis too. But these two diseases are by definition not reversible. So that's the importance of knowing the definition of asthma. I repeat, chronic obstructive lung diseases may have an obstructive pattern on the pulmonary function test, but they are not reversible. That's the important thing here. So if you do, in an asthmatic patient, you do the pulmonary function test, you will see that both FEV1 over FEC and likely FEF 2575 will be decreased. In real life, any one of these two are decreased. It means that this patient has obstructive disease. When they give you the numbers on the pulmonary function test, they give you percent of predicted. So percent of predicted means what's the best thing that you want? Well, you want it close to 100%. Anything over 80, 85% of predicted is considered normal. If this patient, they tell you the FEV1 over FEC has 50% of predicted, right, or 0.50, same thing, well, that's clearly decreased. 50, you shouldn't have only 50% of predicted. So they're going to give you a number like that. It's easy. Anything over 80, 85% is normal. Anything less than that would be abnormal. Either one of these show an obstruction. Either one of these. Now, the other thing that you notice is when you look at the volumes in asthma and COPD, well, remember the X-ray on these patients? They have hyperinflated lungs, flattened diaphragmatic surfaces. That's because they can't blow out air all the time. So if you look at the total lung capacity and the residual volume, in diseases like restrictive diseases, these are always decreased. Correct? In these patients, the total lung capacity will be increased. The residual volume would be increased. So they'll give you parameters like 120% of predicted, residual volume 115% of predicted, because of the hyperinflated lungs. So on the pulmonary function test, evidence of obstruction, usually shown by increased total lung capacity and residual volume. You don't need that to make the diagnosis, but you need one of these two parameters here that measure flow to be decreased in order to say this patient has an obstructive disease. Once you see that, you still have not diagnosed asthma. You've diagnosed only an obstructive pattern, and that could be emphysema, chronic bronchitis, or asthma. But then you give the patient bronchodilator treatment. You give the patient albuterol. Here you go. What do you think happens now to these parameters? They change. They get better. So the FEV1 was 50% of predicted. Now it goes up to 80%, 85% of predicted. It almost normalizes. So you see, this is the definition of reversible disease. If this patient was given the albuterol inhaler and it only changed very little, didn't change at all, it was still 50%, this would mean it's not reversible. And by definition, this cannot be asthma. So asthma means an obstructive pattern and a reversible disease. And that's what you would do in this patient. You'd do pulmonary function tests. You would document that this patient has an obstructive pattern. And then after that, you give the patient bronchodilators and show reversibility. And now you documented asthma. You could tell her she has exercise-induced asthma. What's the treatment of exercise-induced asthma? Well, on the boards, they like to ask about cromolyn. You take a couple of puffs of cromolyn before the exercise, and they do well. Or, in real life, you could also use albuterol. You could take a couple of puffs of albuterol before and after the exercise, and they feel well. Either one, this is a mild form of asthma, could be treated with either one. They like to ask about cromolyn especially, because this is one of the ways that we use it in the adults. Remember I said we like to use this in the children as to not cause the exacerbations of asthma, but it doesn't work that well in adults. It works very well, though, in exercise-induced asthma. So everybody okay with this? So there is still, though, one thing that they could ask you. By definition, asthma is reversible. So the patient that comes into you, sometimes, like our patient here, may have normal pulmonary function tests. If they're not going through a little bit of an asthma exacerbation, they may have normal pulmonary function tests. So here we go. Look at this here now. This is 90% of predicted. This is 90% of predicted. And these are normal. 95% of predicted, 95% of predicted. Could this patient have asthma? Yes, because it's a reversible disease. So sometimes, if they don't have any inflammatory process going on, any exacerbation, the pulmonary function tests will be totally normal. So you say, how do I diagnose this patient? Well, you want to cause a mini asthma attack on them. What's the test to do? The test is called the methacholine challenge test. The methacholine challenge means that you cause a mini asthma exacerbation in them. If you give methacholine to most people in the room, they'll feel a little wheezy. They will feel a little bit congested. But they won't have the asthma exacerbation that these people get. So you give them the methacholine, you measure now FEV1 over FEC, and now you see that it's only 50% of predicted. F2575 is 45% of predicted. You've documented asthma. So it could be documented one of two ways. In the normal pulmonary function test, you do the methacholine challenge, and you document that this patient has decrease in FEV over FEC and FEF 2075, or in the patient that has already an obstructive pattern, when you do the pulmonary function test, you give them a bronchodilator and they reverse later. So everybody clear about that? So one of those two scenarios they will ask you about. So let's go back to our patient here. So they did the pulmonary function test, and this is what they got. The results is the FEV1 is 108% of predicted. The FEC is 111% of predicted, but the ratio is 83% of predicted. So they weren't able, these are normal parameters, they weren't able to find anything abnormal on the pulmonary function test. So what do you do next? This is what you do. You do the methacholine challenge, and now you notice that the FEV1 over FEC, you only have 48% of predicted. So now you've documented asthma by doing the methacholine challenge test. If they don't give you the methacholine challenge test to precipitate an asthma, there's other ways you could do it. You can make the patient exercise or go out into the cold and come back and measure the pulmonary function test. There's other ways to do this. The methacholine challenge test is probably the best way, but sometimes there's reports that sometimes when you give the methacholine, you induce status asthmaticus. So there's a couple of reports of that, so you got to watch that patient. Okay? Very good. So the treatment plan here is inhaled cromolyn before exercise or albuterol as needed before and after exercise. So let me just do the case review here on the differential diagnosis. We talked about exercise-induced asthma. We said that this is a type of asthma variant and that you get cough with exercise with or without wheezing, normal examination, normal chest x-ray, pulmonary function test with methacholine challenge show evidence of obstruction. Okay? Symptoms improve with albuterol and that's all you need to know, or cromolyn. Okay, so I'm going to stop there. We'll take a small little break and then continue with case 3 right after our break.